Darren Wethers, MD CPE, is Vice President of Clinical Operations at Blue Cross Blue Shield of Arizona, where he oversees the full-time and contract physicians, leads the Medical Management Committee, serves as the Senior Clinical Officer of URAC, and is the physician representative on the crisis management team. Prior to entering this role in 2019, Dr. Wethers spent 4 years as the Chief Medical Officer for BCBS Arizona Advantage and 4 years as a medical director at Coventry Healthcare and Aetna. Dr. Wethers practiced internal medicine in the Midwest for more than 20 years, focused on HIV and AIDS and chemical dependency care. It was during this time that he became interested in administrative medicine as a career path. He earned his Doctor of Medicine degree at Northwestern University in 1988 and completed internship and residency in internal medicine at Emory University. He is board certified in internal medicine. He and his wife, Cheryl, live in Anthem, Arizona, where they enjoy hiking, biking, and visiting historic Native communities. So Dr. Wethers, like Dan mentioned, we have a bunch of questions that have been submitted by students. I don't know if you want to kind of give your own introduction, then we can get into the questions.
No, Christopher, that was perfect. Thank you. Let's go to the questions.
Perfect. So yeah, like Dan mentioned, for any students who are here, if you have any questions that come up, you can either just put them in the chat. I'll kind of keep an eye on it and bring them up. And then I'll just kind of read off of the list that I have here, and then we'll kind of listen and go from there. And also, if you want to just ask, you don't need to just write them in the chat. You can just ask Dr. Wethers as well. So first question, what are some of your most memorable experiences from Northwestern Medical School?
I loved that question. I'm glad that we got to lead off with that. I thought back to New Student Week in 1984, and I don't know if they still do this, but we had a student and faculty wine and cheese reception. And that just seemed so classy and grown up to me. I was like, wow, I'm somewhere special. The other thing that came to mind from that time was going to the opening convocation, and our dean at the time, Dr. Harry Beatty, said to us, we're going to create an information overload, and it's your job to figure out how to handle it. And I thought, yeah, you know, I'm a smart guy. I can handle anything this place will throw at me. Fast forward to opening day of anatomy lab, and we had 16 pages of dissection to complete that afternoon. I was like, holy cow, he wasn't kidding. Here we go. And it didn't stop from there. There were some classes we had where the professor didn't even have a recommended text because he said, we're here to teach you what we know. The text is for your benefit and supplementation of what we're teaching in class. All of that was entirely new for me. So those were some of the early memories that really stick with me. Outside of that, it was all of the interaction with people in our class who came from such wildly different backgrounds than my own. I grew up in Chicago. I'm a city kid. I had a roommate in the graduate dorm that year who grew up on a dairy farm in Connecticut. You know, so there were things that he knew and experienced and things I knew, and being in that environment helped us really learn about one another.
Thank you. That's a great answer.
Dr. Cochard, Dr. Larry Cochard in anatomy.
Well, we did have Dr. Cochard, yes.
Yeah, he's still there.
No kidding.
Yeah.
We've all gotten to know him pretty well over the last couple of months.
I would imagine he's a dynamic guy.
What led you to choose your medical school, residency, and current employment at various different institutions? Like specifically qualities of the program, other considerations?
They probably still follow this approach, but we were always told when applying to medical school, apply within your home state, within the home state region. Pick some places you don't think you'll ever get in, some places that might be a shoe-in, and then any wild cards from there. So within my state, I applied to Northwestern and University of Illinois, and then just scattered other ones from there. When I got to Northwestern, though, there was just a feeling about the campus and the energy of the students that I met that day who were so enthusiastic about the institution and encouraging toward me as an applicant, that easily became my number one. And I was really happy to be accepted at Northwestern. But Northwestern in those days was very hands-off for students. You know, you were sort of like fifth in line behind the attending, the fellow, the senior resident, the intern, then you. And I really wanted to have more of a hands-on experience for residency. And at Emory University, you spend half of your time at Grady Memorial, which is a 1,000 bed county hospital. And then the other half of your time split between the university and the VA and private hospitals. So I felt like at Emory, I would learn every form of medicine there was, and it truly lived up to that billing. We can go into this later, but I would say that the business part of medicine found me. It was never something I went looking for. Unlike some in our class who got their MBA while they were pursuing their medical degree or achieved it later, I was invited to do a lot of different leadership things, and it was through that experience that I decided to go into admin med.
Thank you. Next question. Can you share your advice for continuing passions and interests outside of medicine and finding balance while pursuing a career in medicine?
This is definitely do as I say, not as I've done. You have to really fight for your personal space. It's hard now. It'll get harder later, even though it doesn't seem like it could be. When you're in your residency and you're on call and those endless rotations, and then when you start your career as an attending, you think, oh, well, now I'll have all this free time. You really don't. Your time becomes even more constrained unless you really can compartmentalize and block time for those things that make you whole. If you do something artistic, you're going to have to just block time for that. If you enjoy doing things physically like exercise, you're going to have to make it happen. It's not just going to emerge. And I say do as I say, not as I've done, because I serially failed at all those things. It would take others to say, hey, when's the last time you went and worked out? Or my wife to say, we're tired of you snapping at us. You really need to get yourself together. Or even later when I was in practice, I had two people who were counselors who said, you know, you really don't have to come and talk to me, but you probably need to go and talk to someone. And that just like surprised the heck out of me, but it was so on target because I was not keeping it together. And I did need to go to therapy. Something that was incredibly helpful. I did it for about a year. But I think it is difficult for us to maintain balance, and it's okay to get help when you don't.
Thank you. And kind of going off of that, in terms of work-life balance, what is a non-negotiable part of your work and your personal life, respectively? How do you figure that out?
I don't think there's any magic bullet to that. I think it's really just a constant evolution of trying to find your way back to a center. Work is always going to pull you to the extreme, and it's easy to be rewarded for being that person who's there first, who stays the longest, who takes on extra assignments, and you can get lost over there. I think you just have to continually fight back towards center.
And kind of continuing with that theme, what does your typical work week look like?
Now it's pretty cushy. In my current role, it's really an 8 to 5, Monday through Friday, office-based environment. I'm not seeing patients any longer. The medical directors and I do take call 1 week at a time, but it's all telephonic and computer work. We no longer have to go into a facility to complete reviews. But I'll contrast that to the 20 years I spent in practice where I was a bread and butter internist. I still admitted and saw and followed my own patients, had an active office practice. The average day would start at 6:37 in the morning, making rounds before going to the office. oftentimes going in the middle of the day back to the hospital to see patients whom I'd missed in the morning or who had been admitted during the early part of the day, completing office work and going back to the hospital again to make those final rounds before going home at whatever time of day. My wife and kids are fond of saying they never knew when I'd be home, and I didn't either. You know, it could be 6:30, it could be 8:30, it was never at any set time. So they learned to do a lot of routines without me. Again, that's something that I wish I could go back and scrub and do differently. But at the time I was chasing rainbows and slaying dragons.
Then kind of transitioning a little bit, what does the future look like for physician reimbursement and its effects on practice models? For example, are private practices going to continue to be bought up by larger hospital systems?
I'll take that part first. I do think that more and more physicians will be employed as we go forward. Somewhere in the realm of 50% already are, and I expect that's going to continue, just given the way that medicine is evolving as a business. To gain access to some of the pay for performance contracts, you're going to need to be in a system that has the data that you need. You're going to need to be with enough providers to have some contracting muscle. And that's difficult to do by yourself or in a small group. And Christopher, remind me of the first part of the question, please.
Yeah. So what does the future look like for physician reimbursement and its effects on practice models?
So as to reimbursement, I really do think we'll see more pay for value. And I will contrast that by pay for performance, which is a term I hate because in my mind, pay for performance means I'm taking really good care of the patient, making sure that they have great outcomes and they're satisfied. But that really isn't how the contracts are set up. They're set up so that you provide value to the insurance company or to the government. So we need you to give us the information we want about the care of the diabetic member or the mammogram percentage or the colonoscopy percentage that you've gotten done, regardless of whether those particular tests were pertinent for that individual patient. So I say that as someone who works for an insurance company, but that's the part of the business that I don't like.
Right. Okay. What was the turning point for you to enter administrative medicine? Who do you work with on a day-to-day basis, and do you still have time to interact with patients?
When I was in clinical medicine, I got invited to do a couple of really cool things. Early on, it was helping out in a chemical dependency center where a colleague of mine was the senior director, and he and the junior director wanted someone to share call with them. Shortly after launching into that, the senior director took off, and then about a year after that, so did the junior director. So I became the senior medical director of this chemical dependency center. And what I learned there was that the doctor was the least important member of the treatment team. The therapists, the nurses, the spiritual advisors were all more important. And that's kind of mind-blowing because, you know, as doctors, we're used to being at the top of the pops. And in this one, that really wasn't the case, but it was a valuable lesson. That particular center closed, and shortly thereafter, because I was busy treating HIV patients, got invited to be medical director at an infectious disease clinic. Well, if you remember the introduction, I'm not ID trained, and all of the other doctors in the clinic were, but I had experience working in a team-centered environment that many of them lacked. And so I can handle the administrative responsibilities of that and allow the ID doctors to do what they did best. So that was kind of a managing up experience that was helpful. So that experience kind of wrapped up and someone said, would you like to be involved in the medical executive committee of a hospital? I said, what's that involve? They said, you come one morning a month and we give you coffee and donuts. Boom, I'm in. So I signed up for that as a delegate at large for 1 year. And we had a whole bunch of doctors behaving badly during that year, acting out in the operating room, not completing their medical records, the full gamut. And I thought, this is pretty cool. It's like a hospital soap opera. So I signed up for a second year. And we had even more drama between the vice president of medical affairs and the medical staff president having arguments in the middle of the medical executive committee meeting. I was like, this is even better. And they said, you seem to really like this. Would you like to be in line to be medical staff president? So thus began a deeper dive into admin med. And a lot of people finish their term as medical staff president and they can't wait to hand the gavel off to someone else. I was kind of tucking it back because I didn't want to let it go yet. I was having too much fun. And by then I knew that's what I wanted to do long term. I thought it was going to be on the provider side with other doctors, but an opportunity came with one of my old coworkers from my second year of practice who had already started working for a health insurance company. He invited me to be on a couple of committees over there. Before long, I was filling in for him when he'd go on vacation. Their company was bought by Coventry, and when a position opened up with Coventry, I was invited to join them. So I left practice in 2011. And that's why I said in the early part of the questionnaire that administrative medicine found me. It wasn't something I went looking for.
Thank you. There's also kind of that second part of the question of who do you work with on a day-to-day basis? And do you still have time to interact with patients?
I work primarily with our full-time doctors. We have 6 full-time docs who report to me, and I have a dotted line relationship with our behavioral health vice president. We also have a number of contract advisors who support the health plan through their various disciplines. So we have a chiropractor, we have an orthopedic surgeon, and OB-GYN who represent specialties we don't have in our full-time medical staff. Interact a lot with our nursing team, with our case managers. We also have a number of providers who support us from the community on our committees. Dr. Typlin is one of those persons on a committee for us, and it was really gratifying to be able to invite her to participate in that because she was one of my professors when I was a student there at Northwestern. And she was gracious enough to accept, which was really fabulous. So I don't have the patient care interaction that I did during those 20 years previously mentioned. But I'm seeing the reports all of the time and really trying to understand when my doctors come to me and say, here's a young lady who has this inherited neurodegenerative disorder, and the only treatment available to her is a stem cell transplant in Milan, Italy. How do we make this happen? And so then you go into problem solving mode and try and figure out, well, who is the sponsor of her coverage? Is this member fully insured, meaning the risk is all ours? Or is this person covered through a particular employer group that sets its own parameters? And so if it's the latter, then we have to go to that employer and say, here's the scenario for your beneficiary. Is this care that you want to approve, and how do we make this happen? So I think the sensitivity that I get to bring to healthcare, to the care of our patients, is through that type of work that we do. And that's stuff I had no idea about before I got involved in managed care. I always thought when I was a provider that, these guys are sitting there munching on donuts and sipping coffee and just, clicking yes and no randomly all day. They don't care about anybody. but we spend an enormous amount of time trying to get the answer right and to be fair.
Thank you. How have your administrative roles in healthcare shaped your perspective on access to care?
When I first started in practice, I was working in a care for underserved people in Southern Illinois. And also working a lot with HIV patients who were being marginalized in our society. So I think those two experiences were really formative for me in maintaining a sensitivity to the needs of people who had less and lacked access to care. I don't think that's ever gone away. What we have to do, though, in my role is to balance what we see as the need of the individual against what the contractual relationships are. So if you think about your car insurance, for those of you who have automobiles, you know, your automobile insurance is a contract between you and the company. The company says we're responsible for these things, but if you get a flat tire, that's sort of your responsibility. If you need to change the oil, that's also your responsibility. These are things we don't cover. Health insurance is very much the same way. So there are things that are the company's responsibility and there are things contractually that are not. And for those things in the gray area, we have a process for working through them.
Thank you. How do you feel your background in patient care influences your current career in management?
I would harken back to that last answer. You know, also as a middle-aged guy, I have to go to the doctor myself and go and get checkups and follow protocols. I think just being a human keeps you engaged with what it's like to be human and what it's like to be vulnerable.
Yeah, okay, thank you. What have you seen as the biggest change in the patient-physician relationship since you started practicing?
When I started, we didn't have the predominance of what are called physician extenders now, nurse practitioners and PAs. They existed, but they weren't as numerous and they weren't as formally engaged in the management of patients as they've become. And I think that's going to actually grow deeper now that we've brought in more distanced care. So we've got telemedicine as kind of a foundational thing at this point. The pandemic has made it even more so. So what I think will happen predominantly in primary care is that people will engage with the PA and the NP and only occasionally see the doctor. And that's a quantum shift from my early days.
Okay. What's something developing in your field of interest that excites you?
I think the rise of AI is something that's notable, and I'd encourage you all to kind of follow what's happening. I see that being applied in a number of different specialties. Some that you might not think about, like pathology, where they found that, you know, using AI, the computer can read slides of hematologic and other biologic specimen better than a trained physician. Radiology with reading mammograms and other kinds of imaging. The computer makes fewer errors because it has limitless ability to learn. So I think we're going to see additional applications of AI in medicine. On our side of the business, there are also applications through optical character readers and other things that allow us to parse through large volumes of records and be able to pull out the snippets that we need to make determinations. So those may make, you know, physicians even less numerous in my business because we don't need as many people parsing through things manually when it can be done through AI.
Thank you. What is the hardest or most difficult aspect of your career?
I would separate that into two phases. From the early days in practice, dealing with our HIV positive patients. In the era prior to 95, 96, when combination therapies became effective, we lost so many people. And it was overwhelming. I think I still carry some of that sadness to this day. Presently, I would say when you get a chance to do something that's really unique and special. The example I gave of the young lady with a neurodegenerative disorder is an actual example of a problem we had to unravel and solve here. And the more we get to do those kind of things that just leave kind of a heroic feeling, the better. That's the sort of thing that, if done poorly, can go really wrong and can ruin relationships, and done well can solidify them.
Is there anything you wish you had done differently in terms of your career path and training?
If I'd known where I was going to end up, I would have gotten an MBA. So yes. As far as my training, no, I don't regret any of that. I had a blast. Met some remarkable people, and feel like I emerged from both Northwestern and Emory fully able to perform my role as an internal medicine doctor at the top of my game.
Okay.
I do want to share a story. I'm sorry, Christopher, if you don't mind.
Of course.
I was not a great student there at Northwestern. I was a passable student, thank God. I was one of those who graduated, thank you, Lottie. A couple of honors grades here or there, but they were just like, sprinkles on the cake. They were not that numerous. And I remember sitting with my senior year advisor, John Fair. Bonnie, you'll remember John, was an infectious disease specialist, renowned also in HIV care. His daughter, Liz Fair, was, and I guess still is, a rock and roll musician. Anyway, I remember Dr. Fair sitting me down for my senior consultation as I was applying to residency. He was kind of a gruff guy, straight to the point, and he dropped down my file on his desk, frowning as he looked through it, and he goes, "All right, you weren't that great of a student, but you did great in internal medicine. So here's the deal. Here's the top programs in the country. Don't apply to those. You'll never get in. Here are the ones that are crap. Don't apply to those. You'll waste your time. Look at the ones in the middle and come back and tell me where you want to go." And it was like entirely not what I was expecting to have. But, it was direct. It was honest. It was truthful. And I found my space. So what I'll say to all of you is find your space. It could be at the top, in the middle, or the bottom, but find yours.
Thank you. Yeah. And then the final question, at least that I have written down, what are the biggest points of contention between you and non-clinical leaders at BCBS Arizona?
So the non-clinical leaders, they look at numbers, and they say, wouldn't it be great if we put these restrictions on this group of medication? Well, maybe from a financial standpoint, but what's the impact of that to the people at the other end? And how much work does it create for us trying to argue with doctors in the field once we put this in? And do we have any justification for it? When we make a determination to deny something, it has to be based on something. So if I say something isn't medically necessary, according to whom? According to what research? According to what literature? Conversely, if I say something is medically necessary and we're going to pay for it, particularly if there is a self-insured company behind that patient, they want to know why I said yes. So their focus is entirely different too. What I've learned is to be comfortable with my own determination and to turn a blind eye toward what those non-clinicians feel. If I think this is the right thing to do, that's what we're going to do. And, Katie, bar the gate. Not going to concern myself all day and night worried about who's not going to like the determination. I'm just going to focus on making the best decision possible. So far, nobody's locked me up.
Good, yeah. Okay, well, those are all the questions that we had previously submitted, but I think this would be a good time to just kind of open up the floor to those who are here that maybe have a question that came up while you've been answering, or just had other ideas or things that popped into their heads. So yeah, if anyone has any questions, feel free.
I don't want to take the time from the students, but I just want to get your opinion, Darren, on with the change of the presidential parties and the interest in universal health care. What is Blue Cross thinking about the future?
That's a great question, Bonnie. And I know the association has they looked at the election, sort of positioning where things might go. We believe that the Affordable Care Act will be strengthened, and that's okay with us because we have a plan that operates in the exchange. We'd love to see it grow too. By the same token, I think a single payer option, we would hope to be involved in any discussion of. As we've seen before with Medicare, Medicare often uses intermediaries to adjudicate matters and to actually pay the claims on behalf of the government. So if we were ever to get into a single payer scenario, we would want to be front and center there, since we operate in so many markets across the United States and ensure so many governmental organizations and entities. So I think we feel as if the coming administration creates some opportunities for us, just as it creates some challenges. What's interesting, Mohan, I'll come to your question in just a second. What's interesting is that I get to see those inner workings behind the scenes, and to know how this company, as well as many, kind of stay in the middle as close as they can. So no matter which way the coin flips, they end up in a favorable nation status. Mohan, it looks like you were going to ask a question and I interrupted.
Oh, no, please. You mentioned earlier about one thing that you wish you had done is an MBA, and I'm curious, what do you feel like is the role of an MBA, like the value of having that degree, especially in administrative medicine? Did you feel like there's like a glass ceiling to not having it, or do you feel like it's more the didactics, like accounting, finance stuff that you wish you had learned in a more like traditional classroom setting?
I think there are things that MBAs learn that, as far as quantitative analysis, that I missed. I did follow a pathway, the CPE, a Certified Physician Executive Pathway, through an organization called AAPL. I had to complete 150 hours of didactic coursework and then do a capstone weekend of 4 days and a project associated with that. So I took that pathway rather than a formal degreed pathway. And it was solely a matter of convenience and cost. At the time that I was deciding to do that, we had our 2 children approaching and entering college and then graduate school. So the thought of 3 of us in university at the same time was a little daunting. But I do feel that even the CPE didn't give me as firm a grounding in the analytic space as I would have hoped for, and as I see being necessary for that next group of physician leaders. Many of them, especially those entering consulting groups like McKinsey and Boston Consulting Group, many of them never practice. They complete medical school and an MBA, maybe an internship, often not even, and then go immediately into the business world and are quite successful with that pathway. So I think there are opportunities that someone like that has that I'll never be able to pursue because I don't have the same background.
I see. And you mentioned analytic kind of skills. Could you kind of expand on that? Are you referring to finance in particular, or what kind of analytic skills?
And not especially. There's a whole field of data analytics that goes deep into how you munch and crunch numbers. And generally, I go to those people and say, here's what I need. And they close the door and they rumble a lot of things, and then they open the door and pass the platter back. You know, what they do behind those mysterious doors, I almost don't want to know. But they make magic happen, and we rely on them.
I see. Thank you so much for sharing.
You're welcome.
I have a question.
Yes.
In terms of like looking at getting a second degree after you graduate medical school, are you familiar with any like residency programs or jobs that are specifically a little bit more lenient in terms of letting you go back to get another graduate school degree, or will give you some type of like stipend or help pay for you to get like a dual degree?
I think there are some residency programs in some disciplines that have a research requirement. A lot of surgery programs do, some of the other, a lot of fellowships do as well. And so when a person hits that phase of their postgraduate training, they might also utilize that time to go and pursue that additional degree before resuming their clinical work. I've known people who got Masters of Science degrees, say in immunology or microbiology as they were pursuing their fellowships. So those are things that are possible. I think it's a matter of just engaging with the program and finding out what's been their typical experience, what they're able to allow for, what they would consider. If you don't ask, you don't get. And so, you know, my advice would be just ask.
Yeah, thank you.
Any additional questions?
Nobody's asked, like, what was the worst experience that ever happened?
What
I
was
can
the
share one.
Yeah.
So, you know, all of us in med school are just like smart people and self-reliant, but I'll say I was those things, but I was also a procrastinator. And so, you know, in spite of myself, freshman year, spring semester, physiology, I got behind. I had a couple of bad tests, thought I could pull it out at the end, did not, got an F. Like, oh my God, I've never had an F in my life. And so I went and saw the professor, and he said, you know, you did well in the first 2 quarters, but you slipped here. I don't know if it was spring fever or what, but you never came and talked to me. I go, no, you know, I was embarrassed and I thought I could pull it out because I've always pulled it out. And he said, well, you know, so-and-so and so-and-so. And he named people that were at the top of the class. I go, yeah, I know them. He says, they always came and talked to me. They came and talked to me and they made up questions. And I probably gave them the answers to about 10 questions just talking to them. He goes, but you never came and spoke to me. And I was like, man, not only did I fail, but I'm a freaking idiot. You know, I should have been going to talk to this dude a long time ago. So on the heels of that conversation, I went to pick up my mom from the school where she was teaching. And, My mom welcomes me into her classroom and says to her students, here's my son, and he's a freshman medical student. He's not an idiot like you guys. He does his homework. And I'm thinking, oh my word, Mom, not today. Why did you have to tell them that today? So on the ride home, I had to tell her, Mom, I just failed freshman year of physiology. And she goes, does that mean you're going to get kicked out? I go, no, it means I have to study over the summer and take a makeup exam. And, as long as I pass that, I'll be fine. So she's like, oh, but I just felt so rotten. That was like the low point of those 4 years, but it was so instructive. And you best believe I rode my kids on that lesson while they were going through school all the way through grad school. Like, you go and talk to your instructors, even if everything's going well, just get to know them, make sure they know you. Don't rely on thinking you can just bluff your way through, because at a certain point, you're not going to be able to. So Dan, I don't know if any of your other faculty, any of your other alum who you've had conversation with ever said they failed a class, but if not, let me be the first.
I am searching my memory banks. I don't think I've heard it put like that, but certainly connecting with with your professors is always a great thing. And there's in no other field is mentorship more important, and humility too.
Yeah, I agree.
Yeah.
And it's okay to fail. You just get back up, you dust yourself off. But I think we do a disservice to the students and trainees behind us if we don't admit that we've had times when we failed.
Actually, in that regard, if you don't mind sharing, like, what would you say is a mark of a good residency program who helps residents when they're struggling? Like, what are ways that you would recommend a residency program if you were like a program leader to do that?
So let me answer it from the student perspective. Looking at a residency program, I would try and find out what is the percentage of entering interns who are able to complete the full course of that particular training program. There are some that are pyramid programs, and there is a forced weed out at certain levels. So if you see that for what it is, then you'll understand that there is going to be a lot of stress in that program. There may be some backbiting, there may be some infighting between the residents within a particular year because there's only room for so many. Versus those that say, no, we took in 20, we intended to graduate 20. The only reason we won't graduate 20 is if something happens, some act of God or someone gets sick. If people have trouble, we support them, we give them extra time if need be. Some people may not grasp concepts well and they may have to repeat time, but we're committed to seeing them through. That as contrasted to that pyramid program that can't wait for somebody to leave because it makes it easy for them. You could also inquire about any health services that are available. Do they have counseling? Will each person coming into that residency program have a mentor, not just for career development, but for personal things? And those are things I might consider.
Thank you.
I have a question. So this is from a educator's perspective. So just a little bit about my background. Before I came to Northwestern to work in development, I worked in college admissions, college access for students, and I've worked firsthand with students kind of like in an advising type of role. And during your talk, you mentioned if you would have known where you would end up right now, you would have pursued like business, or you spoke also about, I don't know if it was an advisor that told you, hey, don't apply to these, don't apply to that. So what advice would you give someone who considers themselves an educator as far as like aiding students in navigating that? So you got to a certain point, you're like, man, I should have probably pursued,
Mhm.
a business degree. But I have a history of walking students, even now voluntarily, like through that process. So what advice would you give me and other educators?
Yeah, I would say get to know the person whom you're advising and ask lots of questions. What are you interested in? Why? Where do you see it going? Tell me what you think a day in the life of that person would be. Do they have a realistic expectation or do they not? Can you pair them with somebody that's already in that particular role so that they can see it? Um, those are things that come to mind.
Cool. Thank you. Good.
When I first came to Northwestern, I thought I wanted to be a family physician. Um, at the time, we didn't have a family medicine department at Northwestern. That's, Bonnie, you may recall that. I mean, we were hardcore. Family medicine was just like a pittance for some. But we had a family medicine interest club, and it was small but mighty. I was president of the family medicine club for a year. But when I got onto the wards and came to peds, I was at Children's Memorial for half the time and at Evanston Hospital for the other half. And at Children's Memorial, I was up on, I think, the 9th floor, which was hematology, oncology, and sickle cell. I may have the floor wrong, Bonnie, but you'll recall. And as a student, you often had to put in the IV. And I remember walking into a room and the poor little child would just start crying, I don't want an IV. And I thought to myself, I don't want to do it either. And, even though I did well in the rotation, I just had a soft heart. And I thought, oh gosh, these kids break my heart. And outside the room, you had mom and dad arguing, because this poor child with chronic illness was stressing them. And, the dad might say to the mom, you didn't tell me that they stopped liking orange popsicles. And the mom would say, if you'd been paying attention, you'd know. And I was like, oh, no, get me out of here. Send me back to my old people, So I had to change on the fly. Family medicine wasn't going to work if I didn't see little kids. I loved OB. I loved internal medicine. Really loved ER medicine because it combined some of that stuff. But I'm too nosy. I wanted to know what happened when they left the ER. If they went home, did they stay well? If we admitted them, what happened? And internal medicine, I got to know people and I got to follow them for, in some cases, a decade or more. And that satisfied that curiosity. So I share the story to say, don't feel like you can't change course. If you start down a particular pathway and something else interests you, do it, explore it, see what happens.
That's great. Any other questions? Anyone? Well, how about this? Dr. Wethers, would you like to ask any questions of the students? I don't know the last time you were on campus, but any questions about the curriculum or?
I'd like for someone to give me their day in the life. I'll pick on someone if I don't hear any responses.
And mention your year, please, whether you're M1, M2, M3, M4.
So Drew, I'm going to pick on you. Please give me a
All
day
right.
in the life.
So a day in the life. Yeah. So day in the life, typical day, I'll wake up, depending on the day, between like 5 and 6 and go to the gym, come back. We will have lecture that I'll tune into anywhere from 1 to 4 hours in the morning, depending on what the afternoon looks like. Probably take my dog out for a walk and then either go into our like CEC clinic or like CEC learning, like clinical learning, or go to ECMH, maybe have a lecture in the afternoon or like a small group-based learning. and then probably do some studying or review around dinner a little after, and the day relaxing with either some reading or a crossword, so I can just get my mind off things.
It's really important to close, isn't it? Otherwise, you'll be working that stuff all night.
Yeah, I try to cap when I like work. Try not to work past. It depends on like the day, but like definitely not past 10.
Mm-hmm. Good plan.
What year are you, Drew?
Oh, my first year.
First year.
Do we have any second years in the group? Third years? And how about seniors? Okay, so let's hear it from both of the seniors. Maya, you get to go first.
I mean, I'm like kind of a weird fourth year. I'm in this hybrid year. I got like this, for everyone else in the group, Dr. Wethers already knows some of my backstory, but I was awarded the Fogarty Global Health Fellowship that I was supposed to start in last July. And I was supposed to travel to Botswana in July. So that got postponed. So I did like half of my fourth year this fall, and I'm leaving for Botswana at the end of this month to do some maternal fetal medicine research for 6 months before coming back, applying to residency, interviewing, and then going back and then graduating. So it's a whole mess of a thing, but that's where I'm at. The day in my life currently is sitting in my apartment, figuring out travel plans, sleeping, and I started watching The Avengers, all of the phases from the beginning.
Wow.
Because I have time. So fourth year is pretty sweet.
Do you have to get a whole slate of immunizations before you go?
No. Well, I've done a bunch of traveling in the past, so the only thing that I need to get is my typhoid booster and a polio booster, I guess. Otherwise, I am COVID vaccinated and ready to get on an airplane.
Fabulous.
Yeah.
That's living your best life. Dan's giving the big thumbs up. Mohan, how about your day in the life story?
Yeah, I chose the boring path. Now that I think about it, I just went straight. And going into anesthesia, as far as my fourth year goes, initially it was exciting, and then interviews happened, and now interviews are all virtual this year through Zoom. So I've just been sitting back in the apartment doing Zoom interviews for the most part. But that gives me a lot of time to pick up a COVID hobby or two or four. So Queen's Gambit, great Netflix show, fantastic writing, direction, really great costumes. And let's see, I also learned recently how to make really good food with an air fryer.
Cool.
Good wings, all that stuff, and picked up guitar. So hopefully I'll be able to do something with that in residency.
So I think it's interesting that you have to do your residency and interviews virtually, because I, as an interviewee, got so much from being on site and walking the halls and feeling and smelling and kind of, taking in the vibe of the place.
Absolutely.
How are you able to decide?
Actually, Dan knows this pretty well because we talked about this. As you're completely right, we are kind of flying 100% vibeless because we are not able to go there. But at the same time, I think one of the best parts about being a Northwestern student is reaching out to Northwestern alums. And so one of the best ways I got to know the programs is just reaching out. I knew how Northwestern operated, the culture here. I also knew the anesthesia department pretty well. So I know that Northwestern alum could help me compare what their residency is like compared to Northwestern alumni or like the Northwestern culture. So I really got a good sense of it, and honestly, probably got a better sense of the program and how it would fit for me because of that, even better than say physically going there, just to get the sense of like fit. I think the other parts of like, going a place in the Northeast or West Coast or all that, I don't really have a good sampling of weather, which is very true, or like how the ORs look. And of course with anesthesia, that's super important, is kind of knowing where the workflow looks like. But, some stuff I guess are left to surprise.
Mm-hmm.
And guys, I want you to know, Mohan will attest, I'm your guy. I'm the super connector. I have got your back. I am looking out for you. So use the virtual heart-to-heart program that we have. If there's a doctor you're looking for in a place that you don't see there, or a specialty you don't see there, email me, Dan, I'm looking for this. I will find that person for you. It's like my favorite part of my job. And the great thing is, the doctors always say yes because they care about you. I mean, it's really beautiful. Like I mean, you know, I'm talking to infectious disease doctors in the pandemic, and they're like, yeah, sure, no problem. I'll find time. So, you know, utilize that. And then just a quick plug for a post-pandemic program that is going to be great for you guys. Really wish that our M4s could benefit from it this year, but our host program, Help Our Students Travel, we started it about 3 years ago to serve the students. And basically at this point, I have recruited over 300 alums in 36 different states who you can request when you're going to do your interviews for free homestays. So instead of paying $400 for a hotel in San Francisco, we've got alums for you to stay with. Even if you're not necessarily going to stay with them, they're great people and contacts to discuss residencies, preparing for interviews. So definitely utilize that when the time comes. Host is here for you too. Yeah. Dr. Wethers, any other questions for the students?
None that I can think of. I just want to express my thanks for you all joining me today. Hope it was valuable, and wish the best of luck to you all.
Thank you so much.
Fantastic.
Thank you.
Thank you.
Thank you so much, Dr. Weathers. Thank you, Christopher, for
Thank you.
moderating.
Thank
And
you.
thank you all for joining. Thank you, Dr. Typland, for being with us too. Guys, we've got 5 more alumni physicians of Feinberg this winter. They'll actually all be in February. Keep an eye out. Announcements come from your society leaders about a week before. The 5 remaining ones will be on February 1st, 4th, 9th, 23, and 25. We've got doctors with expertise in hematology and oncology, drug development, serial entrepreneurism, infectious diseases, pulmonary disease and critical care, and orthopedic surgery and hand surgery. So, and they're from several different states. So we're taking advantage of the, when you can't bring the alums to Northwestern, bring Feinberg to the alums. So thank you so much again. And thank you, special thanks to Dr. Weathers. We're really grateful for you.
Thank you. It's my pleasure. Everyone be well.